Today I'm going to speak about when diagnosing giant cell arteritis can be difficult. A lot of patients diagnosed with giant cell arteritis have presented with a fairly classic presentation. They're 50s, 60s, 70s or older, relatively rapid onset of a usually unilateral headache with no obvious precipitant. The blood show elevated ESR and CRP. The patient is referred for the temporal artery biopsy, and even if the biopsy does not come back positive, the patient usually responds to high-dose steroids with an almost complete and immediate resolution to their symptoms. It's easy when it's easy. However, there are many cases in which diagnosis is difficult and broader differential diagnoses must be entertained. The patient may simply be generally unwell without any neurological or cranial symptoms. They may be someone who is being investigated for an elevated ESR and CRP with no obvious cause, and all other investigations to date have been negative. They may or may not have associated polymyalgia symptoms. They may have constitutional symptoms like fever, night sweats, malaise, weakness, fatigue or low mood. Even if they do have a headache, it may be the classic sudden onset unilateral temporal headache, but may be intermittent, it may be vague, and can be more difficult to tease out in someone who has a history of headache. There may be the issue of polypharmacy in the older patient. Any neurological symptoms may indeed be transient, such as transient visual loss. The temporal arteries may not be particularly tender, but then scalp tenderness, although it can be present in giant cell arteritis, is not a specific feature and can feature in many situations with headache. It may be therefore that we have to perform a temporal artery biopsy in someone with no cranial or neurological symptoms. The differential diagnosis of giant cell arteritis would include herpes zoster, migraine, serious intracranial pathology such as bleeds or space-occupying lesions, infiltrative or retroorbital lesions, skull-base lesions, other causes of acute visual loss, stroke, TIA, cluster headache, cervical spondylosis, upper cervical spinal disease, sinus disease, temporal mandibular joint disease, ear problems, and other systemic vasculitides and connective tissue diseases. Features that may help differentiate giant cell arteritis jaw pain from non-giant cell would be that in giant cell the jaw pain is more claudicant, present on chewing with no local tenderness. Although the ESR has been classically associated with this condition, I'd suggest the CRP is more accurate and sensitive. It's indeed fleetingly rare for a patient with giant cell arteritis, whatever the presentation, to have a normal CRP. Overall, the headache pattern, site and onset are important. In giant cell arteritis, the headache tends to be sudden onset, constant, unilateral or temporal pain. Occasionally occipital, it tends to be throbbing, commonly followed by visual symptoms. To paraphrase the current thinking in stroke where time is brain, I would support the contention of my colleague Professor Lochmani at the recent international conference, where he suggested that when it comes to giant cell arteritis, time is sight. I'd therefore suggest urgent referral for admission, for assessment, treatment and temporal artery biopsy. If the diagnosis of giant cell arteritis is considered, steroids should be started immediately at 40 milligrams per day, if not 60 milligrams. If you feel vision is threatened, I would suggest up to perhaps 100 milligrams per day, but again, these patients should all be admitted for observation while using such a high dose of steroids. We will ensure that the temporal artery biopsy is undertaken within 1 to 2 working days of the admission. The temporal artery biopsy is still useful even within 7 days of starting the steroids. Some reviews have suggested that only perhaps 25% of temporal artery biopsy for possible giant cell are positive for the condition. We found in a recent review that our percentage of biopsies were much higher. Recent developments in the diagnostic area include ultrasound, which is being used both to help diagnose the presence of vasculitis within the artery, but also to pinpoint the areas of the artery that would be most likely to be positive on biopsy. Ultrasound would have to be used in skilled hands within 3 to 4 days of commencement of steroid therapy. What you're looking for is the so-called halo sign within the artery. The consequences of non-treatment are potential blindness, stroke or scalp infarct. Although blindness or partial loss of vision are the commonest of these, it is still thankfully rare. relative to the amount of successfully treated patients with this potentially dreadful condition. In summary, therefore, think of giant cell arteritis or ephemeral vasculitis as a possible diagnosis both in the patient with classic symptoms but also in the non-specific patient. Try to think of doing an early CRP or ESR and to consider for immediate referral for temporal artery biopsy, while also simultaneously starting high-dose aggressive steroid treatment. 48 hours of a high-dose steroid will rarely cause a permanent side effect, but can commonly prevent permanent blindness.